Hi, everyone. Good afternoon. And thank you so much for hanging around. I'm sure you've been very informed this afternoon with all the very interesting talks so far. And hopefully, and thanks for hanging around to hear me share a little bit about common breast problems and then to understand how we look for what are the features that we look out for and to see if it is cancer. So thanks, PFP, for the invitation to share. So just a bit about myself. I'm Dr. Tang, and I've actually currently practicing with Solis Breast Care and Surgery, and I'm based at Glen Eagles Hospital. Before this, I've had about more than 10 years experience practicing as a surgeon in NUH as well. Just to begin with, um, actually having breast problems are very, very common. About 16% of women above the age of 40 would have some kind of a breast problem over a 10-year period. And fortunately, actually, most are likely to be from a benign cause. However, if you do have a problem, then I would recommend that you see a doctor, probably start with a GP, and then if they need to, they can refer you on to one of the breast surgeons who can then help you to identify the cause of your symptoms. And also then, very importantly, we will also want to exclude breast cancer. So as I said, most of the problems that we see are benign. So maybe let me walk you through some of the common breast problems that we see in our, or I see in my day-to-day practice. So the first thing that I actually see a lot of is something called mastalgia, which is also called breast pain, which is the medical term for breast pain. And it is by far the commonest symptom that we see in our clinics. And fortunately, most of that are benign. And in itself, having breast pain is actually not a risk factor for breast cancer. So if you do see a doctor about breast pain, the doctor will then talk to you and ask you a little bit more about the pain, how long it's been there for, and also whether it's related to your menstrual cycle, whether it's something that comes on every month, and also where the pain is, and whether it's related to any recent exercises that you've done, or whether there's been any injuries. And then when we evaluate, actually, if it's a cyclical pain, then it typically starts just before, about a week to 2 weeks before the start of your menses. And then usually it does resolve once your menses starts or very soon after your menses starts. And this is because the hormones that controls your menstrual cycle does have some effect on the breast and then can cause some discomfort. The other pain that is non-cyclical, meaning that it's there for most of the time or not related to the menses, then the commonest cause for that is actually from the muscles behind the breast. Because behind your breast is actually big muscles that controls your shoulder and arm movements. So sometimes the pain can be from that muscle or even the ribs that are just behind it. And that can be what we call costochondritis, which is inflammation of the ribs. So those are actually fairly common. And if you do see a doctor with breast pain, then often we would recommend an investigation. If you're above the age of 40, we would suggest you do a mammogram, not because we think that it's because of cancer that you have the pain, but it's good to check to make sure that underlying there's nothing wrong or there's nothing sinister. And if there is, the doctor finds that there's a lump around the area of the pain, then they will do an ultrasound as well. And the good news is, most of the time, the pain actually will just get better by itself. It can take a couple of weeks sometimes or a couple of months, but by far most of the pain will get better. And if it doesn't get better, simple things you can do is to make sure your bra is supportive and well fitted. Try to limit your caffeine intake. Some women, if the pain is very bad, they may need some simple analgesics like Panadol or anti-inflammatories like ibuprofen. Or evening primrose oil has been found, some women find it helpful for kind of a cyclical hormonal type pain. So you can try that for 1 or 2 months to see if that makes any effect. So another common symptom that we see is lumps in the breast. And by far, most are also benign, especially if they are in the younger patients. However, it is still the commonest presentation of cancer. So if you do have a lump, do see a doctor where we will evaluate the shape, the size, the mobility, whether it has been changing, getting bigger over time. And also, if you have a lump, then see a doctor because we would like to exclude cancer. And how do we do that? We do that by something called a triple assessment, which involves a history where the doctor asks you about kind of your background, your risk factors, the story about the progress of the lump, and then they will examine you. And usually we will do some kind of an imaging or some kind of a scan. If you're above the age of 40, that usually involves a mammogram and an ultrasound of the area as well. And usually if you do have a lump, we will do a biopsy, some kind of a biopsy. Usually it's done with a needle. So we take a small sample, send it off to the lab, and then they can analyze it and tell us what type of lump it is. And one of the commonest types of lumps that we see that is benign is called fibroadenoma. It tends to happen in the younger age group, below the 30s, but it can actually happen throughout all women of all ages. Some of them, they can grow rapidly during puberty or pregnancy, but often it grows a little bit and then it stays fairly stable. So if your doctor has confirmed that the kind of lump that you have is a fibroadenoma, then often it doesn't require very much treatment because it is very, very, very low cancer risk. But very rarely, sometimes the doctor will recommend monitoring it because very rarely cancer can also develop within the fibroadenomas. So it's important to monitor if you do have a lump to see if there's any changes or any growth. And if there is, then your doctor would advise to consider taking it out because we want to evaluate and make sure that there's nothing else that's or that's causing or has changed within the breast that has caused the lump to grow. If you are keen to take the lump out because of pain, just a word of caution, because sometimes the pain may not resolve after the lump is removed, because the pain is often related to the tissues around it rather than from the lump itself. So another cause of lumps that's benign that we see is cysts. And most of that, basically a cyst means that it's a pocket of fluid within the breast. And there's lots of different types of cysts, but by far most of them are harmless and benign again. And sometimes the doctor will also recommend to either take the fluid out just to make sure that there's nothing else within the cyst, or also if they think that there's some tissue within the cyst, then they may suggest that you do a biopsy of the tissue portion of the cyst. But again, these are mostly harmless. So besides lumps, the other thing that we see sometimes is patients with nipple discharge. So nipple discharge is very, very common in women who are breastfeeding. But sometimes in women who are not breastfeeding, they can happen. And again, most are again harmless. And if you see a doctor, then we will ask you questions asking, is it just on one breast or both breasts? Is it that the fluid leaks out on its own spontaneously, or do you need to express and press and then the fluid comes out? And what comes out? Is it just clear, colored, transparent fluid, or does it have any blood within it? And whether when it comes out, is it just from one spot, indicating that it's just from a single duct, or whether it's from multiple spots, whether there's a multi-duct discharge. And also when the doctor examines you, then, or if you have examined yourself, then you can check, is there a lump associated with it? So most of the time, nipple discharge is actually from natural or what we call physiological cause. From nipple stimulation, if you stimulate it or you express it often enough, your breast thinks that you're trying to feed a baby. So they will also produce a little bit of fluid, even though it will just come out as just a serous transparent fluid. Or if it's milk that comes out in medical terms, we call it galactorrhea. Then the commonest cause is actually from medications, or rarely there might be a sign that there is something else sinister in the brain that is causing hormonal changes that has triggered it. So your doctor will need to evaluate that as well. And if your symptoms are more that is from one side, the fluid leaks out on itself and it's quite bloody, then the ones in the red box tends to be a little bit more sinister. So then we would need to exclude something else more sinister underlying it. And among the diagnoses that I've put there, again, reassuringly, most are also benign, but occasionally it can signify that there's an underlying cancer. So it's important to see a doctor to evaluate that further and for your doctor to do the necessary tests to find out what's going on. Another common symptom that we see is also mastitis, which means inflammation or infection of the breast. And again, it's very common, or it's most common in women who are breastfeeding or lactating, and often it's related to either blocked ducts or an engorgement. And the patient presents with a red, hot, swollen breast that's very, very painful. And usually it affects women from their first child, after their first child, because the women are not as experienced in breastfeeding. And how it happens is that there is a skin break, and then the bacteria that normally lives on your skin can enter the skin through the skin break, either in the nipple or on the skin itself, on the breast, and then it can go into the milk and infect the milk. And the commonest bacteria is what we call Staph aureus, which naturally lives on everybody's skin. And we usually treat that with antibiotics. And in most of the time, it actually is fairly effective. And then we want to drain the milk as much as possible. But in some patients, it may go on to develop an abscess, which is basically a pocket of pus within the breast. And if that's the case, you often need a drainage procedure on top of just antibiotics. And we can drain it with either a needle, where we just use a needle and aspirate out all the pus, or using surgery and actually make a slightly bigger hole and then drain out all the pus. So if that's the case, if you do need surgery, some women may have to stop breastfeeding to allow the wound to heal properly. And also they often require regular dressings at the wound area as well. Now, I've covered basically not all the common benign problems, but I think these are the common symptoms that I see in my regular practice. So maybe I'll just share next a little bit about breast cancer, because that's what a lot of women are worried about. And in Singapore, breast cancer is by far the most common cancer in females, and it accounts for 1 in 3 female cancers. And it's thought that about 1 in 13 women will get breast cancer at some point in their lifetime. And if you look at the chart there, it shows the statistics in Singapore for the last 40 to 50 years. The number of women getting breast cancer is increasing. And if you look through the next chart, basically this shows you the age of the women when they get breast cancer. And it can unfortunately happen to women at all ages. However, if you're very young, then it is not very common. And the incidence does increase as you get older. And from about 40 onwards, it increases sharply. And the peak is about 50 to 60 years old. And then it tapers off after that. Unfortunately, most women are diagnosed at a fairly early stage. So stage 1 and stage 2 are what we call early breast cancers. But unfortunately, there is still a proportion of women that are stage 4 when they are diagnosed. And hopefully with more education, that we can try and minimize that number. So we can try and cure all patients with breast cancer. And I think I just saw a question about prognosis. So basically, actually, breast cancer prognosis is very, very good if you compare among all spectrums of cancer. As you can see from this chart, most women who are diagnosed at stage 1 to stage 3 do well in the medium to long term. And the earlier you are diagnosed, the simpler your treatment is. And it can take just sometimes 2 to 3 weeks of downtime. And then sometimes even as you're going through treatment, a lot of my patients sometimes do return to work even while they're undergoing treatment. So as you can see, the survival rate and the cure rate is actually very, very good. And even in stage 4, where it's thought that the cancer has spread to other parts of the body, there is still good treatment that can slow the disease down and that can offer most women some kind of a good quality of life during their treatment, and then we can slow the disease down that some of them still can live on for at least a good couple of years after that. And how do they present? As you can see here, breast cancer can present in lots of different ways. Like I mentioned earlier, the commonest presentation is still breast lumps, but sometimes you can present with changes on the nipple, either crusting, ulceration, skin changes like a non-healing wound, new onset sudden redness that doesn't get better with any antibiotics or any treatment, changes to the way the breast shape is or the size. So if you have any of these symptoms, do see a doctor to get it evaluated to make sure that there's no underlying sinister cause to these symptoms. And the risk factors for breast cancer actually there's largely divided to what you can control or what you can't control. And a lot of it is what, unfortunately, we can't control because the biggest risk in itself is just being a woman. By far, women get breast cancer much more than men. And also, as we get older, which we can't stop ourselves from getting older, then also that in itself is a risk. The others also related to family history. So if as other people in your family with breast cancer, then that can also increase your risk. However, hereditary breast cancer actually only accounts for a very small percentage, 5 to 10% of breast cancers that are diagnosed and treated. The other risk factors Some are controllable and some are uncontrollable, but are largely related to your hormone exposure throughout your lifetime. So, meaning when you first started having your menses, when you have your menopause, whether you've had children, how many children you've had, whether at what age you've had your first child, and whether you've breastfed any of them, and whether you wanted to take any extra hormone replacement therapy after the menopause. So, these are your hormonal factors that can affect breast cancer. The other things that you can do to try to help yourself or minimize your risk of getting breast cancer is to avoid obesity, um, and maintain a good, healthy lifestyle with normal weight and also regular exercise. It's thought that if you exercise 30 minutes each day for 5 days a week, that can also reduce your risk of breast cancer. Also, try to cut down on your alcohol intake as much as possible, because that can also increase, if you take too much alcohol, that can also increase your risk of breast cancer. So if you can't kind of fully prevent it, then what we would recommend is actually to consider screening, because the earlier we can pick up breast cancer, the better the treatment is and the better the overall prognosis is, as you can see from the charts earlier. And above the age of 40 would be when most governments around the world, and certainly Health Promotion Board in Singapore, suggest that you consider doing mammograms. And besides mammograms, you can also consider doing breast self-examinations monthly, where you can check yourself as you're lying down sometimes, or when you're in the shower, usually with your hands, with a little bit of soap on your hands, just have a gentle massage on your breast to see if you can feel any lumps underlying it. And if you do choose to have a mammogram, then the recommendation is for 40 to 50 to do a mammogram yearly, and 50 and above to do a mammogram every 2 yearly. And if there's any abnormalities, then you will be referred to one of the breast surgeons to evaluate it further. So then if unfortunately you do have breast cancer, a little bit about breast cancer. Basically, it's thought to be a spectrum disease where it's from normal and then the cells do small little stepwise changes to become abnormal and then progressively more abnormal to a pre-cancer stage, then true cancer. So it can happen in a few areas in the breast. The main one is what we call invasive ductal carcinoma, where changes happens in the ducts, or the other one would be invasive lobular carcinoma, which the changes happens in the lobules. And now we can classify breast cancer to different subtypes based on the molecules or the receptors on the breast, because this can help us guide treatment and also gives us an idea about the prognosis and the outcome of the disease. And in terms of the treatment, just to touch a little bit about the different types of breast cancer treatment, usually the treatment is delivered with what we call multidisciplinary care. So there's different doctors who will be involved, and then also other healthcare professionals like the nurses, the physiotherapists, and also sometimes the pharmacists, and the doctors that are involved often involve a breast surgeon, a radiologist, an oncologist, and also a pathologist who will cover different aspects of the treatment. And the treatment also often is what we call multimodality treatment. So there's treatment to the breast area, which is local regional therapy, which is usually surgery or radiotherapy, or systemic treatment, which is treatment that goes through the whole body, which is goes through your blood either, or you take tablets. So that's hormonal therapy, chemotherapy, or targeted therapy. So we call that systemic therapy. And also, if the local regional treatment usually requires surgery. So because breast cancer usually starts within the breast, and that they can go to the axillary or the armpit lymph nodes. So surgery usually involves two areas: surgery to the breast and also surgery to the armpit lymph nodes. And the surgical options actually depends on the stage, the type of cancer you have, the size of the cancer, and then whether you have any other health problems, and also your lifestyle and your personal needs and wants. And because there is a variety of options, it allows the doctor to tailor the treatment to suit you and to return you to hopefully a good quality of life and to where you were before the diagnosis is. So that you can actually have a good quality of life after surviving cancer. And how we do surgery, then the options are either you can have a mastectomy, which is removing the whole breast, or breast conserving surgery, which is just removing the cancer area itself. And if you do have a mastectomy, you can choose to have reconstruction or not. Or if you do breast conserving therapy, then there's different methods we can use to remove the the lump, and we sometimes also call that lumpectomy. And if we don't have reconstruction, then we would recommend women put a little prosthesis or a gel pad within their bra, and they can carry on uh, uh, in their normal clothing, and so it's not very obvious to the people that they meet in their day-to-day practice. And also, if you choose to have reconstruction, then there are various options. And if you choose to have lumpectomy, then you often need radiotherapy together with it. So when we do breast conserving therapy or lumpectomy, we basically take out the cancer and then a rim of normal tissue around it. And often the surgeon can hide their scars in areas that are not very obvious, so that you can, some women are okay to wear like even a bikini outside after the surgical treatment. But often after lumpectomy, you do need radiotherapy to the rest of the breast to stop the cancer coming back. And now there's a new technique called oncoplastic surgery. Basically, it's oncological surgery, meaning we remove the cancer, and then also plastic surgery techniques to maintain the cosmesis. So it gives you a good cosmetic outcome, even if you have larger tumors, and then that can give you a better quality of life also after the treatment. And if you do have to have a mastectomy, we remove the whole breast. And this can be what you look like after surgery, where women are flat chested with just a flat scar across, but they can then wear a bra and put a prosthesis inside, and they can wear their normal clothes. And if you do choose to have a reconstruction, there are various reconstruction options. A common one is using implants. It's the same implants, silicone implants that are used to make your breast a little bit bigger, but here it's used to maintain and return your breast to its normal shape and size. So it's used in a slightly different manner, but essentially it's the same type of implant. Or the other common option is using your own tissue. And the commonest one is using your tummy, where it's basically like having a tummy tuck and using the tummy tuck tissue and putting it into the breast area to build a new breast for you. But of course, if you use your own tissue, then there are longer scars and a slightly longer recovery time. And when we do axillary surgery or surgery in the armpit lymph nodes, we have a special technique to find the first few lymph nodes that drains the breast. So we call that the sentinel lymph node biopsy. And if there's cancer to find within the first few lymph nodes, then we may need to take the rest of the lymph nodes away, called axillary clearance. And besides surgery, some women may require chemotherapy. Basically, what it is chemotherapy are drugs that are used to destroy rapidly dividing cells. So they can be sometimes given before surgery to try and shrink the cancer so that we have a smaller part of area that we need to take out. Or if you've had surgery already, it's given after surgery so that we can try and minimize the chance of cancer coming back. And basically, what it involves is usually for breast cancer, most of them are drips, and you need to go to hospital at regular intervals every couple of weeks for a drip. And then after the drip is done, it can take a couple of hours, and then you can go home and rest. Now, many patients are very fearful of side effects from chemotherapy. However, I would just like to try and reassure women that actually nowadays with modern medicine, there's a lot of medications we can do and the oncologist can give you to try and control the side effects so that hopefully that can minimize the side effects from chemotherapy. So there's hopefully no need to be too fearful about it. The other treatment is radiotherapy. Radiotherapy is basically using X-rays, and then we target it at the breast area so that we target the X-rays to try and minimize the chance of cancer coming back in that area. And the dose of X-rays that we give is tailored to each patient, and then so hopefully that there is much less side effects. And actually, the downtime from radiotherapy is fairly minimal because it's just daily hospital visits for about 15 minutes over 1 to 6 weeks, depending on the type of cancer you have and the recommendation of your oncologist. And so a lot of my patients who have radiotherapy actually carry on working during this time. The other treatment option is hormone therapy. Basically, these are tablets that are used to cut down the amount of hormones in your body, so to minimize the kind of hormones that can stimulate the growth of your cancer cells. Often these are just tablets that are given over 5 to 10-year periods, and they tend to be fairly well tolerated with very limited side effects. Okay, just the last treatment actually is what we call targeted therapy. And this is probably the newest type of treatment within breast cancer, where we use special treatment to find and fine tune and target at special characteristics within your cancer cells itself, and then that can stop its growth. And the most popular one, or the oldest type of targeted therapy, is something we call anti-HER2 therapy. which is a drip that's usually given with chemotherapy. And then that can also stop the cancer from coming back. There are lots of other new targets that are being developed and treatment that's being developed. So this is a constantly evolving space, and then there's new treatments now. So with that, I end my talk, and thank you very much for listening.